think you're all aware that I favor using any kind of technology that I think will improve my patients' outcomes and the best implants that are available. And I trained to do total hip replacement, as we all did, with a posterior approach. We did acetate templates to determine our neck cuts. We used some kind of intraoperative jig to get our cup anteversion and inclination, and we used these calipers to get our leg lengths. And still, you would end up with these unfortunate x-rays occasionally in the recovery room. And you can see what happened here. The cup was placed too vertical without sufficient anteversion. There was an attempt to gain stability by adding length, and now you have a terrible situation of a leg length discrepancy and an unstable hip. So we've implemented technology in every facet of our operation, from preoperative planning to intraoperative tools with real intelligence hip and postoperative assessment. So the digital templating, I think, is the standard, and this is very helpful for us to assess the patient's anatomy, type A bone, type B or C bone, so we can pick our stem, cemented or uncemented, collared or uncollared, and even look at the type of stem we're going to use to reproduce their offset and our neck cut for the leg lengths. But what's more interesting and complicated is the dynamic factors. How do we assess the patient's spinal pelvic mobility? How do we know their spinal pelvic tilt on the table? And how does this relate to their activity? So we know that when we put a cup in, it doesn't stay in the same position when the patient is moving about. When the patient stands, the pelvis rotates forward. This improves our femoral head coverage. And when they sit, the pelvis rotates backwards, which helps relieve impingement anteriorly and gives us posterior coverage to prevent dislocation. So normal spinal pelvic motion tends to help us. A normal arc of motion has been defined as about 30 degrees. The challenging patients are the hypermobile patients, where they have an arc of motion of more than 40 degrees. And in those patients, I often use dual mobility, and you have to really put the cup in the center, or the sweet spot in the center of their arc of motion. More commonly, we see patients who have a stiff spine where they're stuck in a seated position or stuck in a standing position. Stuck in a seated position is more common, and this can be the result of surgery or result of arthritic change. And this is a major cause of late instability. So the question is, for every patient, is the ideal cup position 40 and 15, 40 degrees of inclination and 15 degrees of anteversion? And probably not. There are plenty of papers like this that show that even if you're in the center of the Lewinick zone, you can have up to 60% of your dislocations with the cup in this position. So my question is, what is the optimal cup position based on the patient's individual spinal pelvic mobility? So we get a standing AP pelvis, and this gives us our functional position of the pelvis. And you can see the arthritis in the spine, so this patient's going to have a stiff spine. And we get a supine with our calibration markers, so we can do our templating. But we also get a lateral of the pelvis standing and seated, and we measure the sacral slope. And we're really curious about the change in sacral slope between standing and sitting. And this patient is really stuck in a seated position with less than 10 degrees of motion. So we know that when the patient's stuck in a seated position, that increases the functional anteversion of the cup. So if I put my cup in my normal position of 20 degrees, this patient will have an actual functional anteversion of 38 degrees, and I'll have anterior instability. So I need to put the cup in with less anteversion, and my low anteversion becomes less than 5 degrees. So what we've done to deal with this is we use fluoroscopy to help us. And whether you do an anterior approach or a posterior approach, and I use both approaches as needed for the patient, fluoroscopy will definitely help you. And we're looking at having a shallower ellipse on an anterior approach hip. And this patient has appropriate anteversion, has done well, and has a stable hip. But I've often wanted to have more information. So we helped develop over the past 4 years this application called HipPro. And what this does is it takes your lateral radiographs standing and seated, and you can measure your sacral slope, and then insert that information into a 3D modeling software and vary the position of the cup and determine the ideal position for stability and range of motion. So this is what the screens look like. The opening screen, we have the x-rays that are imported, and you draw the anterior line between the ASIS and the pubic symphysis. This defines your anterior pelvic plane, and then you mark out the sacral slope. And then you classify the pelvis into stuck standing, stuck seated, normal range of motion, or hypermobile. And we can simulate what happens to the body because we have digitized all this information, all the joints and all the muscles. So for golf, all the way from the backswing to the follow through, and we can summate the information of the contact pressure and neck impingement. So of course we want to centralize our loading and minimize impingement. We can look at this for getting out of a chair, getting on a bicycle, reaching down to the floor, going downstairs, and even doing yoga. So we can summarize this data and say what happens to our impingement diagram and our stability diagram when we change the cup inclination, cup anteversion, and stem anteversion. We can even change the modular components, change the stem, change the cup, and you see things that you'd expect: better stability with a larger head, less stability with a skirted head, and we can come up with an ideal cup position for this patient, 48 degrees inclination and 16 degrees anteversion, and we see what happens with different implant combinations. So how do we execute this plan? What is the patient's position of the pelvis on the operating room table? What is their pelvic tilt? So the standing AP pelvis gives us an idea of their functional pelvic position, and you can approximate this on the table with x-rays. And in most patients with a supple spine, when they stand up and when they lie flat, their spine and their pelvis is in the normal alignment. But if they have a flat back deformity and a stiff spine, then their pelvis may be retroverted on the table. So you have to adjust your thought process because you want to put in your cup relative to this anterior pelvic plane. Well, every 1 degree of pelvic tilt will change your functional anteversion of your cup by 0.7 degrees. So when I'm putting an anterior hip cup in, I'm looking for this ellipse. If it's less anteversion, I'm looking for a smaller ellipse. But again, I want more specific information. And what if I don't have great imaging? And what if I'm doing a posterior hip in a lateral position? Well, we have TraumaCAD, and TraumaCAD allows us to do the static templating, but it also allows us to input these special points. And if you input these special points and you know the sex of the patient, then you can determine their native pelvic tilt. And this is a function of mathematical relationships over many, many patients that are sex-related and landmark-related. So now we can incorporate this information into our navigated total hip replacement. So we have pre-op x-rays. You don't need a CT scan. And I think a CT scan is necessary for some cases with very difficult anatomy, like dysplasia, but not for the routine case. The pre-op plan with TraumaCAD gives our implant size and our femoral neck osteotomy. And now we know preoperatively our goal cup position based on the dynamic factors. And intraoperatively, I want to know my cup position, my leg length, and my offset, and I want to be efficient. So you can use this system and you can get a total hip done in about 30 minutes through a posterior approach. It's suitable for any approach, anterior, posterior, lateral, all are very suitable. And it uses instruments that we're used to from navigation, trackers with infrared arrays, and there's a tracker for the pelvis and a non-invasive tracker for the femur. And then we have a navigated cup insertion tool and a probe for entering data. So when you fire up the machine, you select right or left hip, male or female patient, supine or lateral approach. Pretty straightforward. You put this array, it's a non-invasive array on the femur, and this allows us to restore the femur to a zero position. So you're always bringing the femur back to the exact same spot when you're measuring leg length and offset. This array is mounted in the iliac wing. It's very straightforward. The small pins go between the tables of the pelvis. Now, if you're in a lateral position, you're going to register the ipsilateral or the high ASIS and the L5 spinous process. And then when you register the acetabulum, that gives you your third point to define the anterior pelvic plane. If you're doing a supine approach, a direct anterior approach, you just register the ASIS on both sides. We then insert a checkpoint marker in the greater trochanter. We bring the femur up to the zero or neutral position, and we register that location. So then after we put our hip in with our trials or our final components, we can measure the change in position of this checkpoint to determine change in leg length and offset. After we do our femoral neck osteotomy, we can map the rim of the acetabulum. We also map the central fossa of the acetabulum. Now we've defined the anterior pelvic plane, and you can navigate relative to the anterior pelvic plane or relative to the table. And what you'll find is that if you're using a navigation relative to the anterior pelvic plane, the numbers will look more familiar. But when you start doing your calculations involving the pelvic tilt of the patient, then your numbers will look less familiar, but then you can navigate relative to a virtual x-ray. And this is an actual screen. So basically, you're trying to line up the purple dashed line with the yellow target line. This is navigating to the anterior pelvic plane, and this is navigating to the supine plane or the functional plane, and it looks like you're navigating relative to a virtual X-ray. So now we can define a target precisely and hit that target precisely with our acetabular component position. Then we insert our trial components, we reduce the hip, we bring the femur back to that 0 position, and we can see that we've added 4 millimeters of leg length and added 4 millimeters of offset, and according to our preoperative templating, that can be our goal. We have a navigation certificate at the end of the surgery telling us all this information, and again, all this data is integrated into a digital ecosystem where you can relate the patient outcomes to your plan, to your execution. So I think that this integration of technology is very helpful, pre-op planning with TraumaCAD and HipPro, allowing us to now use this dynamic information, which is unique, and then navigation gives us the key information. Where's our cup going? What is the leg length? What is the offset? It does not interfere with our operative flow. We don't need a C-arm in the operating room. It increases our operating room efficiency. And then we use these same tools to assess our outcomes of the patient and measure our location of our components. So thank you very much.